This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. In case you don't know, I'm a MedPeds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh at the Paul C. Gaffney Division of Pediatric Hospital Medicine. Now, we've been coming to you with this podcast since October of 2016, walking through the American Board of Pediatrics content specifications for pediatric hospital medicine. As you know, along the way, there have been some bumps in the road. COVID was a notable one. There have been some others where we've had to veer off and do other stuff, which we did, and we are always coming back to the content specifications. Now, if you've been a fan of the show, and I'm going to give a shout out to my mother-in-law here, who has brought this up to me numerous times. Years ago, I want to say 2018, we did an episode titled Breastfeeding 1. And whenever you title something 1, that means there should be a 2 at some point. And I promise you I have been meaning to get to it, and I haven't. But now, here today, we have a very special episode, and it's partially thanks to our wonderful guest. And just for transparency for all of you listening, this would not have happened without our guest, so I'm going to give her a thanks before I introduce her. So we are doing here Breastfeeding 2 with our expert guest, Dr. Carly Dulabon. Dr. Dulabon is a board-certified pediatric hospitalist and internationally board-certified lactation consultant. She completed her medical school at University of Toledo College of Medicine and residency right here at Children's Hospital of Pittsburgh, which, before I keep reading as an aside, it's always wonderful when one of our residents can come back on the show as an expert guest. I truly get just such a kick out of it. I love it. She is now a pediatric hospitalist at Akron Children's Hospital and works in the newborn nursery and special care nursery at Wooster, Ohio. She has spoken with the Institute for Breastfeeding and Lactation Education on breastfeeding multiple times and on their podcast on breastfeeding multiple times. She's the vice chair of pediatrics for Wooster Community Hospital and is the collaborating physician for their nurse practitioner breastfeeding program. So without further ado, Dr. Dulabon, thank you so much for taking the time out to be on the show and help us out with this.
Thank you for having me. I'm very excited.
All right. Carly, as you know, this is a CME podcast, so we have to do our disclosures. I will go first and kick it out to you. I was on an advisory board for the Sanofi Corporation for meningococcal vaccination in immunocompromised patients, which should have no bearing on what we are doing here today. Carly?
And I have nothing to disclose.
All right. Now, Carly, this is our second round doing this. For those of you listening, there was technical errors on my part. So Dr. Dulabon here has been kind enough to do this all again, which is the first time we've had to do that, and I apologize for it. But Carly, I think we wanted to start with appropriate weight gain in breastfeeding and basic physiology, just to kind of refresh everybody.
Yeah, I think it's really important to just go over kind of the what is normal in order to differentiate when something becomes abnormal. So generally, appropriate weight gain for a breastfed baby, the kind of rough and dirty way to do it is a baby should double their birth weight by 4 months and triple their birth weight by a year. What that kind of breaks down to is in the 0 to 4 month range, they should be gaining about 5 to 7 ounces a week, or about roughly 20 to 30 grams a day. I know we weigh babies daily when we're kind of keeping track of things, but I think it's really important to look over the course of a week, just as more of an average, because some days they'll gain and some days they'll lose, and we don't want to kind of pinpoint just a change on one day. From 4 to 6 months, it's about 3.5 to 5 ounces a week, or 17 to 18 grams a day. So it does go down a little bit. 6 to 9 months is about 2 to 4 ounces per week, or 10 to 13 grams a day. I think one thing to really make note of when you're discussing weight gain and weight loss in babies is the birth weight versus the 24-hour weight. So when a baby is born, obviously they get weighed fairly right away. And then usually they get weighed again at 24 hours. That weight loss in 24 hours is almost exclusively diuresis. So whatever fluids mom got during labor, so if she had a long labor or ended up with a C-section or something like that and got a lot of fluids, that 24-hour weight loss percentage is probably going to be much higher than a baby whose mom came in and had a quick labor or something along those lines. There actually isn't a huge difference in that 24-hour weight loss between a breastfed baby and a formula-fed baby because, again, it's not nutritionally related. It's much more related to just water losses from being in the in utero environment and then transitioning to the outside world.
Okay, so if I got this right, the weight doubles at 4 months, triples at a year.
Correct, roughly, yep.
Roughly, and it sounds like roughly the first 6 months you can gain. I'm going to summarize it, but you said it more specifically. So if you're listening later, go back to what Carly said: 20 to 30 grams a day.
About, yep.
And then after 6 months, that drops to like 10 to 15 grams a day.
Yep, exactly.
And then the first 24-hour weight loss is pure diuresis, depending upon how much fluid mom got, how much she needed prior to delivery. There may be more or less. So it really is more relevant on how the delivery went from mom's perspective than whether the baby's breastfed, bottle fed, or anything else.
Exactly. Yeah. So, I mean, I'm much more concerned about a baby who loses 8% of their birth weight from day 2 to 3 than I am about a baby who loses 8% of their birth weight from birth to 24 hours.
So then do you count day 2 as the weight you're going to really focus on when you're in the hospital?
So I do.
You do.
We are working with our group because it's just a newer kind of thought process. And there have been articles that have come out in the past couple of years saying that it's actually more accurate to base your weight loss off of using kind of the 24-hour weight as your baseline weight. Obviously, you take into account, what their first day weight loss was, but yeah, I generally look at their 24-hour weight as kind of their baseline, and then see from there what their percent change is after that.
Okay. Now that's your basic weight gain in breastfeeding. And in terms of comparing it to bottle feeding, is it more or less or the same, would you say?
So in general, it should be about the same. We know that there are risks to having greater weight loss for, all sorts of reasons, whether it's mom's milk supply or baby's poor latching. But if all is going well and mom has an adequate supply and baby has an adequate latch and baby is being put to breast an adequate amount, that actually weight loss in a breastfed baby is not that significantly different than weight loss in a formula-fed baby.
Well, since you kind of touched on the technique and whether mom is having enough supply or not, do you want to do physiology of breastfeeding?
Sure. So we'll step into just the basics of physiology because we actually know quite a bit about breastfeeding and the physiology behind it, although probably not as much as we do in a lot of other body systems. But so one thing I think is super interesting that I didn't actually know until I started kind of teaching myself a lot of this breastfeeding stuff is that milk production actually starts during pregnancy as early as 16 weeks. So if you have a mom who has like an 18-week loss, for example, her milk could come in because she's already started producing colostrum. This kind of early milk is known as secretory differentiation or lactogenesis 1. And progesterone of the pregnancy inhibits prolactin. So this is why moms don't get like a full milk supply until after delivery. Lactogenesis 2 or sensory activation is what we commonly call milk coming in. So this is triggered by the delivery of the placenta and the withdrawal of the progesterone from that placenta. So this usually is, somewhere between 1 to 5 or 3 to 7 days after delivery, kind of depending on the parity of the mom and route of delivery and kind of some other factors. So naturally, this would be delayed by retained placenta because then they're still getting progesterone. One thing that's really of note for us, especially us as newborn hospitalists, is that betamethasone, so celestone that we give moms for maturation of baby's lungs can actually delay secretory activation or mom's milk coming in. So it's a really important thing to note that if there is some delay there, it could be caused by that. Obviously, I'm not telling anybody to not give betamethasone shots because, baby's lungs are more important, but it's just something to consider.
They got to breathe before they can eat.
Right. Exactly. If they're not breathing, they're not eating. So, yeah. And then milk does come in regardless of nursing. So that immediate control is endocrine based. So whether there is stimulation of the breast or not, milk is going to come in. And then galactopoiesis or lactogenesis 3 is kind of that long-term maintenance of breastfeeding. And this is what's under what we call autocrine control. So it requires stimulation at the breast. And this starts at about 10 to 14 days after delivery, and volumes kind of completely level out and regulate around 4 to 6 weeks. So this is your typical, what we hear of supply and demand, which is really more so demand and supply long-term. And this is controlled by prolactin. So prolactin is what's stimulated by suckling and pumping, and then oxytocin is what controls that milk letdown. So I think, breast milk is, maybe I'm a little biased, but breast milk is so cool compared to other sorts of really anything that baby could take in, is the milk composition changes all the time. So it changes throughout the day. So milk that is pumped or fed overnight in early morning tends to be higher volume, and it tends to be fattier. So those middle of the night feedings are really important for baby's growth. Milk changes throughout the lifespan of the baby. So the milk that a 2-day-old gets is very different than the milk that a 5-month-old gets, which is very different than the milk that a 9-month-old gets. So it's also different for preemies, which I think is really important to know. So donor milk is great, and we know that it can help prevent NEC and provides lots of other good stuff, but it's just still not quite as good as mom's milk in these scenarios, because mom's milk is made for a preemie, whereas donor milk is pooled milk from all sorts of moms.
Carly, can I interrupt you? You're saying so many good things. I have so many questions. So back to the 16 weeks is when breast milk begins to be produced. So if you have, unfortunately, a mother, let's say she has an early loss, 20 weeks or so, and either you're seeing her as a pediatrician taking care of the other kids that she has, or as in what you do, lactation consultant, do you then, or would you recommend, or would you tell her to expect to perhaps need to pump for a couple weeks, or what would you tell her to do?
So there's a couple ways to go around this, and it really kind of depends on what the mother's wishes are. So we do have some moms who prefer to actually pump and provide breast milk either to donate or to give to other kids, or, whatever they choose to do. But if this is not something that she's interested in, then generally we would tell her the same kind of suppressive things that we would tell a mom who chose to formula feed after her milk came in. So things like cold compresses, you can take ibuprofen or some sort of NSAID around the clock to help with some of that edema and that inflammation that comes, like the engorgement that we hear about in those first few days after delivery isn't actually milk. Most of the time it's just edema and inflammation from
Is that
all
right?
of that activation. Yeah. So it does kind of come with mom's milk, quote unquote, coming in, but the engorgement itself is not, it's mostly edema.
Okay.
So you could have mom kind of counsel her on the same sort of mechanisms that you would use in a mom who was just choosing not to breastfeed for whatever reason.
Okay. So then that's normal stuff, the cold compresses, or if she wishes to pump and donate, that's fine too.
Correct.
And then you said betamethasone, if given for lung maturation, can suppress or slow down milk production. So when we would full disclosure for those listening, at our division, I do not do any newborn medicine. So if you do, some of these questions I'm asking may seem rudimentary, but bear with me. So when we have kids that come in for Fair to Thrive, or not really Fair to Thrive, poor weight gain in the first couple of weeks, or even hyperbilirubinemia of the newborn, which we think is due to breastfeeding jaundice, which I think the name has changed, but I never remember the new name. We should be asking if they got steroids, and if they got steroids in utero during the delivery, it's not a surprise that they're coming in and mom's milk is delayed. That's expected, and then we should be doing whatever's necessary to help. Is that fair?
Yeah, exactly. So it shouldn't be delayed like weeks necessarily, but it could be delayed several days, which obviously in the realm of, trying to feed a newborn, several days can definitely make a difference. So in those several days, they may need other sorts of, either mom may need extra stimulation, so pumping on top of feeding, or donor milk or formula supplementation. But I think it's important to note when you're trying to find a reason why mom's milk coming in may have been delayed, to kind of ask back, like, did she get steroids during her pregnancy? Because, if it's mom's 10 days postpartum and her milk hasn't still hasn't come in, your differential diagnosis is all sorts of things as to what it could be. So that's why it's important to ask about pregnancy-related things.
And we're going to get to failure to thrive or trouble gaining weight with a breastfeeding mom later in the show. But so you then also said along the failure to thrive lines or trouble gaining weight, the overnight feed is full of fat. So if you're having a kid with any trouble gaining weight and mom says to you, because everybody wants to sleep, right? I mean, I don't know of one person who was ever like, I'm getting too much sleep. It's just crazy. I've never seen a new parent say that.
Right. Or an old parent. Like,
right. Nobody ever says it.
Right.
So if they're saying, my child is sleeping through the night, it's wonderful, then you may say to them, well, actually and if they're exclusively breastfeeding, the overnight breastfeeding is the fattiest. So that's an easy adjustment you can make to perhaps help weight gain. Is that fair?
Yeah, and honestly, a lot of times all it takes is adding just one overnight feed can make a huge difference. So if they're going 8 hours overnight, adding one feed at the 4-hour mark-ish can make a huge difference because it's a fairly high volume of milk and it's a fairly fatty content of milk. It's also really important for mom's supply to have that overnight stimulation because prolactin is highest overnight. So if she's going 8 hours without any sort of emptying or stimulation, then that's not great for her supply either. But yeah, the middle of the night feed, I know everyone wants to get rid of it. I get it. But it is probably the most important feed. So I'm
going to put you on the spot.
Yes. Oh gosh.
How do you have any idea in terms of numbers? What is the difference? From overnight feeds to daytime feeds, what's the range of difference? And I can edit this out if you don't know. That's totally fine.
Yeah.
In terms of fat content, or is it like 50% more, like 20% more?
I don't know the exact kind of science behind the exact number difference. And I'm sure it's variable depending on, because milk fat also changes like depending on how long since last feed and like how old baby is. So I don't know comparatively like how, to milk earlier in the day off the top of my head. But there's so many factors that go into it. Like the overnight feed for a 4-month-old is even going to be different than the overnight feed for like a 2-week-old in its fat content. So it's hard to say.
Can you talk about that? How is the overnight feed change? How do the feeds change in terms of age? Does the protein content go up or like what changes?
Yeah, so it's interesting. So one thing to really note, and this is particularly important, I think, when it comes to talking about failure to thrive in breastfed babies, is that volumes gradually increase over 2 to 3 weeks of life. So over the first few weeks to a goal of 24 to 32 ounces a day, and then they stay there. So unlike a formula-fed baby who gradually needs more and more formula as they grow, a breastfed baby doesn't. And the reason for that is that the breast milk actually changes as the baby gets older. For the most part, it actually gets fattier. So the fat content increases as the baby gets older up until about 6 months. And then with the introduction of solids, depending how solids are going, breast milk volumes gradually and slowly decrease until about a year. But for the most part, it's actually the fat content that increases over the first 6 months to increase the caloric density of the milk to kind of keep up with the larger size of the baby.
So then our next, for those listening, we have a couple of points. Breastfeeding with late preterms we want to talk about and failure to thrive. So we're somewhat mixing them up here, but I'm really enjoying this because so when I have a kid admitted, let's go back to hyperbilirubinemia.
Okay.
And they have a child admitted for that, and it's clearly breastfeeding jaundice. Just either mom's milk supply or the child's not extracting it. And let's say the mother wants to exclusively breastfeed, and you have a mother who got steroids at the end for lung maturation, maybe to late preterm. What advice would you do? Would you supplement with formula for a couple of days to give mom that time and for the baby to gain the weight and get the volume they need? What would you do? So
the hyperbili folks may feel different, but honestly, the formula supplementation is a treatment for dehydration. It is not the treatment for phototherapy. If you're worried that the baby is not getting enough, especially in those late pretermers who are obviously at higher risk for hyperbili, the first step is always to feed the baby. So if mom does not have enough milk and baby is showing signs of being dehydrated, then you have to supplement. Okay. Generally, what we would recommend in this instance, though, is what we call triple feeds. So put baby to breast if the baby is showing interest, and then have mom pump. and feed back whatever milk it is that she is pumping after nursing. And that's kind of the best way to supplement is always with mom's own milk. So giving back whatever she can produce after a nursing session can help with your volumes, especially in your babies who are kind of just lazy nursers, which a lot of those hyperbilly babies are, especially if they're late preterm. But yeah, supplementing with mom's own milk is always the best way to do it. If mom doesn't have milk and you feel that baby is showing signs of dehydration, then you would go to donor milk or formula. If the baby is nursing well and weights have been fine and doesn't look dehydrated and just has simple hyperbilly, then I would not recommend formula in this case for a multitude of reasons, including you can actually damage the breastfeeding relationship even with just a day of formula. It does permanently alter the gut microbiome of the baby, introducing non-sterile formula. The other
One day will alter it.
It does, yeah. And I'm not by any means anti-formula. There is a time and a place for it, but if it's not needed, then it can actually alter the gut microbiome in just a day. The other thing that I think sometimes we often forget to do with moms when we are supplementing formula is, again, anytime a supplement is given, mom should be pumping, because what happens is the supplement is given, baby is no longer hungry, so baby no longer then is stimulating the breast as much. So if baby isn't stimulating the breast as much, then supply isn't being stimulated as much. So if we're giving formula, mom should be pumping at the same time. Even if she is getting 0 drops of milk, she should still be pumping to give her breast that stimulation, because that's her, way of saying to her body, hey, we need more milk. I'm having to do something else other than nursing. So that's something to always remember. And I see it all the time that we're supplementing babies with formula and mom is not pumping.
All right. So if it's breastfeeding jaundice, the child's not getting enough volume because either they're lazy feeders, let's say if they're late preterm, or mom's supply isn't fully in, the first step, if mom wants to exclusively breastfeed, is to give her have her feed, have her pump after her feed, and give back what she pumps.
Exactly.
And then if that works, the child gets enough volume not to be dehydrated, Billy comes down, then you're okay.
Exactly. Yeah.
If it's physiologic jaundice, then it's just fine. They can feed right through it.
Exactly. Yeah.
And then you also said you get to a max volume when you're breastfeeding, no matter what age the baby is, of 24 to 32 ounces, and the breast milk changes in terms of calories and fat and protein to adjust to the baby's needs. You never go really higher than that.
No, I mean, we see like a rare instance where a baby may need a little bit higher, but like never. So, I mean, I've seen like, if you calculate for formula kind of things, it's always 20 calories an ounce. So they're getting up to like 40 ounces a day, 45 ounces a day. Like I would never see a breastfed baby get that high in their volume. And if they do need a volume that's that high in order to gain weight, then I would be looking for some other reason why they're not gaining weight.
Okay. Now, we've talked a little about late preterm in the sense of when they come in with hyperbilirubinemia. Is there any other differences in breastfeeding if you have a late preterm versus a term baby?
Yeah, definitely. So the late pretermers, I think, are probably the hardest group when it comes to breastfeeding. So those are, you're like 34 to 37 weekers. We kind of like in the breastfeeding world call them great pretenders. So they sometimes will look like they're nursing great and they're not actually transferring anything. I feel like they're harder than your preemies because we expect them, like, oh, they're only, a month early, so we expect them to do better than they actually are. But these babies often require some sort of supplemental feeding. So these are often the moms that you'll find that are pumping after feeds and feeding back because baby just isn't quite able to transfer milk adequately in order to gain weight. A lot of times we give moms the goal of, usually they start to figure it out about 40 to 42 weeks corrected. So like by the time they get to their due date or a couple weeks after, which is later than a baby who was born at like, say, 38 weeks. Because it's harder to learn how to feed outside of the womb than it is on the inside. These are the babies that I would almost always have following up with either a breastfeeding medicine physician or a lactation consultant because they're going to be supplementing pretty much for at least several weeks. And so they need just very close follow-up after they do go home from the hospital.
So when you say transferring milk, you literally mean the baby sucking on the breast, getting the milk out and swallowing. That's what transferring means.
Yep, exactly.
And so they'll have more trouble doing that. And so they'll often be supplemented. This is the 32 to 37 week, 34 to 37 week group.
Yep.
Okay, I didn't realize that.
Yeah, just their coordination is just poor for the most part. So their strength, and this is why they can look like great pretenders, because their strength is not horrible. So a lot of times they can look like they're latched and they're suckling, but their coordination is poor, and they don't have the like peristaltic tongue movements that they need to really fully extract the milk. So like on the surface, they look okay, but like once you actually get into their mouth, they're not doing what they need to do.
And when you say peristaltic lung movements, Carly, you literally mean the tongue does a peristalsis and kind of gets one drop at a time, from what I remember, puts the nipple on the top of the mouth and does a peristalsis and gets one drop at a time. Is that right?
So it gets several drops because there are usually several openings for the milk ducts within the like nipple areolar complex. But yeah, it's a slow kind of pulling motion. There's a video on YouTube. It's like one of my favorite videos, but it literally shows the tongue of a baby who is nursing, and it looks like a peristaltic wave going through, and so it pulls the milk from the breast, and they have to have the coordination to do that versus like a bottle where they can kind of willy-nilly suck and it's gonna come out as long as the nipple is compressed. So it's just a very different mechanism and sometimes can take some practice for both babies and moms.
And that suck, swallow, breathe reflex that babies will get, I don't know if the proper term is better or stronger, but it works better with breastfeeding than bottle feeding, meaning they're less likely to aspirate with breastfeeding than with bottle feeding. Is that correct?
Yeah, much less. So we will oftentimes let our preemies go to breast, and if they get a few drops, that's great, long before we let them bottle feed. And the reason for that kind of goes back to that mechanism is a breast is not going to supply any milk without the right stimulation and the right movement. Whereas a bottle, like even a uncoordinated baby can chomp down on a bottle and compress that nipple enough that milk will come out. So it takes a lot more for them to manage the milk flow of a bottle, whereas they can kind of self-manage the milk flow at the breast.
That's fascinating. Now, that's a late preterm. Now, we've kind of talked about the peristalsis, and we'll get to tachypnea and bronchiolitis. That's one of the things I really want to talk about.
Yeah.
What about if we have a failure to thrive patient being admitted an ex-preemie, so before that 34-week range, X 32 weeks, X 28 week, coming in with failure to thrive, and mom wants to breastfeed. Are there anything specific we should be thinking about?
Yeah, so for the most part, once they reach kind of corrected term, so once they reach like their actual due date or a couple weeks after, their growth parameters actually are generally the same as if they were born on time. So it'll be the same volume. We do sometimes see babies that just need a little bit higher volume or a little bit higher calories when they're super, super preemie for growth. But for the most part, once they reach corrected term, they should be kind of treated like any other baby.
Okay.
When it comes to calculating calories and looking at feeds and growth and things like that.
And you said already, but I think it's worth reiterating that the breast milk, if mom is exclusively breastfeeding, will adjust for the child as the child grows. So short of there being a transferring issue, I learned a new vocabulary word, the child we should be able to try to just breastfeed and see how it goes. And last time we had talked, so just to round out this failure to thrive section.
Yeah.
Initially, you had said pre and post weights are a pretty good judge if you get multiple of them throughout the day. So one in isolation may not be helpful. But if you're admitting a child for a few days for failure to thrive, outpatient workup hasn't worked, you can do multiple of these pre and post weights as long as it's done correctly, and it'll give you a rough estimate of how breastfeeding is going, how much is being transferred.
Yeah, I actually like using pre and post weights in babies. So I almost never do pre and post weights in babies that are on fluids. So that's one thing to keep in mind. If you have a baby who comes in and is actually dehydrated and on fluids, then pre and post weights can only be so helpful because they're on fluids and you don't know how their body is responding to those fluids. But generally, if you're doing multiple, so like a full 24 hours worth of pre and post weights, it can give you a kind of a nice rough estimate. Pre and post weights have kind of fallen a little bit out of favor in a lot of places because, they'll go to a lactation appointment as an outpatient and they'll get one weight and they're like, oh, well, they only transferred a half an ounce, so you need to be supplementing. But like the one weight pre and post doesn't tell you anything about what they did the rest of the day. Like, well, what if they get 25 ounces in all their other feeds that day? Then who cares if they only got a half an ounce for this one feed? But they can be helpful when you're doing them correctly for like an extended period of time, like a good solid 24 hours or even 48 hours, just to give you a rough estimate, like, is this baby actually getting enough? And if they are, why are they not gaining weight? Or is it just a volume thing?
And for our listeners, we recognize that most of our hospitals are still understaffed. So this is clearly like in that mythical hospital that is fully staffed that day, and you're able to have what we call the PCT or nursing assistants help and weigh these kids all day long. It's an idea. I didn't realize it was helpful, so I appreciate that.
Yeah, I mean, it is, you're right, it's technically difficult because they have to be there before feed. And like if you have a fairly young baby, they could be feeding 10, 12 times a day. So now you're weighing them 10, 12 times a day. So it can definitely be technically difficult and demanding in the hospital setting.
Now, Carly, for our kids that come in are exclusively breastfed and they have to be NPO for surgery, for something, what should we be doing to support mom? Besides, I think most of us give mom a hospital grade breast pump if she wants one, but what else should we be doing?
So I think one of the complaints actually that I've heard from moms is that the hospitals don't have anywhere for a mom to store her milk. So there should be a place with patient labels that she can store her milk. And it can be stored in either a medication fridge, although it doesn't have to be. It's not considered a hazardous substance. It's not a bloodborne substance, like if you drew blood and it couldn't sit, obviously, in the fridge. But also teaching mom how to use the pump. So your nursing staff or you guys, if you really feel so inclined, should be able to understand and recognize the basics of the pump, how to turn it on, the suction, the rate. We generally would recommend, it kind of depends on the age of the baby, how often to be emptying, but a safe bet would be Q 2 to 3 hours during the day with 1 4-hour stretch overnight. Obviously, if you have a mom of a 1-year-old who is NPO, for example, they may not need to be emptying every 3 hours during the day. So in that case, you can kind of follow like, well, if baby feeds every 5 hours during the day, like that's probably fine. But for the most part, we would recommend Q 2 to 3 during the day with 1 4-hour stretch overnight. And that's for a mom whose milk is already in. They've been breastfeeding. This is not for the mom who's like trying to bring milk in per se, but whose baby is made NPO for whatever reason.
And last time you told me, and I didn't know this, that the hospital grade breast pumps are better than even the ones you can buy over the counter, or especially the hand pumps or the portable ones that are now more popular because the suction is better. Is that correct?
Yeah, the suction is better. It's a little bit stronger and it tends to be more consistent versus the wearable pumps, especially. The pumps that like most insurances provide now are considered hospital grade. So like the Medela and the Spectra are considered hospital grade pumps. But if you have a mom of a baby who's going to be NPO for a prolonged period and she's not used to pumping, a lot of times the ones that we have actually in the hospital can be better. They also tend to just last longer. Like the motors don't run out as easily. So if you have a mom who's pumping a lot, it may matter. But
okay.
But especially compared to like a hand pump or one of the wearable pumps, they're not ideal for a baby in this scenario.
Now, Carly, I definitely want to talk about bronchiolitis. After this year, we've had a lot of bronchiolitis, and hopefully this next year upcoming will not be as much bronchiolitis for everybody. But there's a couple of scenarios, and I'll let you pick where you want to start. The first one is your child on the hospital medicine floor, not yet in the ICU, and some hospital medicine floors may or may not have high-flow nasal cannula. But let's just say the child's tachypneic, 70 breaths per minute. When do we decide on NPO, and is it different for purely breastfeeding kids? The second scenario I would love to talk about is the child has left the ICU, had RSV bronchiolitis or bronchiolitis, and it happens in our hospital sometimes where they were intubated for a while and they did a swallow eval afterwards. And this is a purely breastfed child, and they failed the swallow eval. How should we interpret that in a purely breastfed child? So I'll let you pick which one you want to start.
We should interpret all of that with a grain of salt. I think it kind of goes back to whether aspiration of breast milk is actually a problem at all. So there's been a couple articles now that have come out. So there was an article in the Journal of Peds Otolaryngology. And so it was a fairly small study and it was a single institution. But what it showed that in breast milk fed infants with documented dysphagia, so like your kiddo that had a swallow study that showed that they were aspirating, all of them continued to breastfeed and they all remained healthy despite continued intake of breast milk. Even though they had proven on swallow study that they were aspirating, clinically, it didn't matter. So it showed like 90%, sorry, I should clarify, 90% of those babies had no problems. 10% did have problems. And when we're talking about problems, we're talking about respiratory illness. So not reflux or not vomiting, but true respiratory illness. So recurrent aspiration pneumonia. 6 of those remaining 10% had a laryngeal cleft as well. So essentially 90%, but you can even say probably more than that because those 10%, 6 of those 10% should have been excluded, had chronic aspiration and 0 respiratory problems. So it kind of comes down to like, does it matter if your kiddo is aspirating? There was also a study in children with bronchiolitis who require high-flow nasal cannula, so maybe your kiddos that are a little bit sicker, and it showed that feeding-related adverse events, so progressing to intubation or aspiration pneumonia, were considered rare, regardless of the feeding method, whether it's breast milk by direct nursing or by bottle. Again, kind of alluding to that breast milk is not as damaging to the lungs or damaging at all to the lungs when it is aspirated. So it kind of goes down to, kind of your risk benefit a little bit. I think I should say one other thing to really consider is I almost always let my kids direct nurse versus bottle feeding if they are kind of like teetering the line of worsening or they're tachypneic. And it kind of goes back to what we were talking about earlier, where a baby feeding at breast is much more able to self-pace and self-control versus a baby feeding at a bottle. Breast milk only flows if baby is making it flow, whereas a bottle is going to flow regardless of suck. So in a baby who's tachypneic, they may be much more likely to aspirate with a bottle being fed than with nursing directly. Again, you can kind of decide whether it matters if they aspirate breast milk at all, but taking it regardless, like your baby who is tachypneic is probably fine to nurse pretty much all the time. The only time that I really think it's worthwhile to make them true NPO is if you're worried that they're going to be intubated, because obviously having a belly of milk is not ideal if you're getting ready to intubate a kid. But if they're like steadily tachypneic, then I think personally that we should really kind of consider whether they're safe to nurse, especially because nursing is comforting. So you have a baby who's much less fussy. There's also a hydration aspect. I mean, we all know that aside from the respiratory standpoint of bronchiolitis, there's the dehydration standpoint that kids get admitted for. Well, if you're letting your baby nurse, like that may be enough just to keep them hydrated and enough to either keep them out of the hospital or keep them from getting an IV or IV fluids.
I mean, that it's interesting because I think back to Hurricane Maria that hit Puerto Rico years ago. We did an episode on it. But the thing that happened was most of the IV fluids for the continental United States were made in Puerto Rico. And for that period of time, we didn't have IV fluids. We had very little. And that's interesting information for something like that, to where there's an IV fluid shortage, let's just say, knowing that the child, because I think you said the last time we recorded this, that the first little bit of breastfeeding and during the day is almost all hydration?
Not during the day, but during a breastfeeding session in and of itself. So the early milk, what we call the foremilk, so kind of like the front milk, is high in lactose and low in fat, meaning it's got a high sugar content and it's very watery. And so it is basically like quenches baby's thirst.
Okay.
And then what we call the hind milk is higher in fat and higher in calories. So yeah, it's hydrating.
It's hydrating.
Aside from just caloric.
And it's funny, I don't know that this is why we have you on as an expert guest, but it makes sense that if you were going to have humans create a milk for humans, it shouldn't damage the lungs. It would just make some logical sense. Now, I didn't design the system, but it makes sense.
It totally does. And there's some actual thought that like reflux, like physiologic reflux, is actually a protective mechanism because so we know that breast milk has immunoglobulins, particularly IgA, but it also has like lots of other infection fighting cells, including lysozymes and white blood cells. So there's actually thought that reflux is physiologic because it's a protective mechanism. So it coats the esophagus and it coats the linings of the nasal mucosa and the oral mucosa to prevent infection. So there's kind of, makes you wonder, are we actually like almost meant to aspirate a little bit of breast milk for a mechanism of lung protection, for kind of the same mechanism of protection in the, like the GI tract and the nasal tract?
Now, I always knew breast milk had IgA, but you're saying it has lysozymes and what else?
So many good things. It has leukocytes. It has lactoferrin, which is an immune cell. It has lysozyme. It has mucin. It has cytokines. So we generally think of IgA as like the main immunoglobulin, and it's the most important. And it is. It's very important, and it's really important in preventing GI illness, but there are lots of other good infection-fighting cells in the breast milk itself. So actually, here's a fun fact. In IgA-deficient moms, so we do see IgA-deficient moms from time to time, their breast milk is actually also IgA-deficient, but their babies don't see any increase rate of infection. Like they have the same infection rates as other breastfed babies, which we know tends to be less than formula-fed babies. So it kind of just goes to show that there are lots of other good infection-fighting cells other than just immunoglobulins in there. Yeah,
really fascinating, and it's just so interesting because, as you and I and our listeners know this. Each bronchiolytic baby in front of you is an individual child, and no two babies or bronchiolitis are going to be the same. So when I now have one, I'm going to take some of this information into account. But for those listening, please make sure to evaluate your patient individually and decide, clearly if there's a concern and if you should make them MPO, et cetera. But it's so fascinating to talk about this because I did not know breast milk really is not pathogenic from what we can tell so far. And I am excited to hear where the literature goes with this because I'm assuming there's more and more studies happening.
There are, and I would bet over the next couple of years, a lot more will come out. And I think as hospitalists, we kind of have the benefit of having the kid in front of us. So, if we let him feed and we see, okay, maybe he's getting worse a little bit now. Like, let's see what happens if we stop him from feeding. Does it change anything? Like, we have that benefit of watching the kid the whole time, as opposed to like in the outpatient world where they get sent home. So it is kind of nice having a minute to minute, change to see how they're tolerating breastfeeding. I mean, for all we know, they could be nursing and nothing changes. So then great. So we have that benefit.
But we also, the flip side of that is we see the sickest of the sick. So the 6 kids with the laryngeal clefts probably discovered because they were admitted to an inpatient hospital setting. Right. So we have to keep our ear. So again, it's super, super helpful. It's fascinating stuff. Now, did we talk about everything you wanted to with tachypnea, with breastfeeding during bronchiolitis or aspiration? Did we cover everything?
The only other thing I wanted to mention was this other article that came out, which I found fascinating. So the study population was actually congenital heart disease babies, which is obviously not our typical, but those kids are sick, probably sicker in a lot of instances than our bronchiolytics. And in all of the patients in this study, they allowed them to nurse on demand, and none of them had a single desaturation with nursing. So in patients that are even maybe sicker, so it's just kind of more, information to put into our thought process.
Yeah, as more data towards what you're saying, teaching us is that the babies who are direct nursing really have a way of self-regulating that we are maybe starting to understand better.
For sure.
And Carly, as the literature evolves on this, we're going to ask you to come on when new stuff pops up to help us through it. I'm hoping that's okay.
I would love to. I can talk about this until I'm blue in the face.
We're very happy about that. Now, the only other thing we wanted to talk about was the change in true contraindications of breastfeeding, especially from the last time we recorded this.
Yeah, so the main one let me just first say that the main actual big change that the AAP made since last recording was they actually now recommend, in conjunction with the WHO, so the World Health Organization, to support moms and their breastfeeding children until age 2. So it used to be to always support until age 1, and so they actually upped it to age 2. But I should note that the natural age of weaning of a breastfed baby or a breastfed toddler or child is actually somewhere between 3 and 7 years of age. So if mom doesn't choose to wean, the baby will generally naturally wean even later than that. So that's just a change from when you guys did Breastfeeding 1 a couple years ago. But the other kind of big change is regarding HIV. With the advent of so many new great HIV medications, it is no longer considered a true full contraindication to breastfeeding. So a mom who has her HIV with HIV with a viral load of 0, so undetectable, who is well controlled and compliant with medications and follow-up, actually has pretty much a nil risk of transmission to baby via breast milk. So obviously these are the moms who you're going to have infectious disease involved and
Sure.
things like that. But it's something that we should be counseling moms on, that this is now an option for this patient population.
That is fascinating. Okay.
Yeah. The only other things that I kind of just wanted to touch on is THC use in breastfeeding moms, which we are seeing at least a lot more moms open about it now that it's legalized in lots of states. We know, so THC, we know, concentrates in fat. Well, breast milk and breast tissue is very fatty. That's why it's so good for baby. Mm-hmm. Unfortunately, THC then concentrates in breast milk, and it is found. So if you test breast milk for THC, it will come back positive.
Okay.
We don't know the long-term effects on baby, obviously, because this is a fairly new thing, but there has been some links to developmental delays in ADHD and other sorts of things, kind of like in that realm. There's obviously been no controlled studies, and there probably will be no controlled studies because you can't, tell
can't ethically do it.
Exactly. But this kind of comes down to counseling as well. So a lot of hospitals have policies. So if you're listening, follow your hospital policy. But there is no great oh, mom should pump and dump for 2 weeks, or mom should pump and dump for a month, or whatever, because it's highly variable how long it stays in mom's system. So the correct and kind of best counseling would be for mom to stop her THC use if she chooses to breastfeed. We all know.
That's hard.
We can only do the best we can. But
yeah. So if you, or if the breastfeeding specialist, such as yourself in general, if you have a mother that says to you, I do not want to, nor will I stop taking THC, is the consensus among the specialists to recommend bottle feeding then for those mothers?
Yeah, I personally would recommend formula feeding if mom is a chronic THC user. Yeah. Yep. Unfortunately, but yeah.
Okay. And if it was, I don't know, one time, then if it was one time and the mother tells you, okay, I'm done, how long?
Yeah, so this is where it's hard to say, but generally I would tell a mom that if it was this one time thing, that she could just resume.
Okay.
Immediately, because we don't really know. It's highly variable, how long. Even if you test a mom on a drug screen, who knows how long she'll test positive for after a one-time use versus a chronic use. There's so many factors. So if it's not chronic use, if it's a one-time thing, then I generally tell moms to resume, that they can resume immediately.
And now you said 3 to 7 is baby-led weaning from breastfeeding.
Yeah, the natural age of weaning. Much later than we really think about.
It is. I mean, last time it's a cultural shift, and maybe that's why the AAP and WHO said this, is to kind of get everybody thinking this can go later than a year, and that's normal.
That's exactly what it is. It was their effort to normalize it a little bit beyond what our culture treats it as normal, and it is a very United States thing and a very westernized thing to think it's weird or whatever to breastfeed past a year. But yeah, the main reason for the AAP kind of changing their stance was to help normalize breastfeeding beyond a year. Because they're still getting all of the good stuff that comes with breast milk, all of the immunoglobulins and all of the infection fighting cells. It's still there even after a year. So
yeah, and the one thing I have noticed is when older kids who are still breastfed here and there are sick, that's almost exclusively what they want.
There's a comfort aspect for sure to it.
Yeah. And
yeah,
it's
one of my kids got sick. He was 16 months or so. And I swear that it was the only thing he would drink was he would nurse. And I'm 100% sure that it kept him out of the hospital from getting IV fluids because that was all that he wanted. But it was enough to keep him hydrated. And so that's important.
Yeah. And that's what I've noticed is those kids will get hydrated purely from breastfeeding and will take nothing else.
Yeah.
which is...
But, wouldn't you rather them feed their gut than feed, their IV? So, exactly.
Gut is always better. Right. It's never the wrong answer.
Right.
Almost never the wrong answer.
Right.
All right, Carly, what else did we miss, or what did you want to talk about that I wasn't skilled enough to ask?
There is just one more thing I wanted to touch on, and that's lead poisoning, because we as hospitalists do see kids with lead poisoning. So lead is present in breast milk. So if you have a baby who is breastfeeding, or like a sibling of you have a patient who's admitted and they have a breastfeeding sibling, then that breastfeeding sibling should also be checked, because we know that lead is present in breast milk, and presumably the mother is in the same environment as the child. If you have a baby who is breastfeeding who has high lead levels, then mother should be tested and checked. And if mother also has high levels, then she should also complete chelation if her levels are high.
Oh.
Because she can just continually pass on lead through her breast milk in a breastfeeding baby. So it's just something to consider. I know a lot of times we see lead toxicity in older children,
Sure.
like kids who are old enough to crawl and walk and put things in their mouth, but it is not out of the realm of possibility that, a 1-year-old who is in that age is still breastfeeding.
So if you had lead poisoning in the 2 or 3, 4-year-old, but they have a 6-month-old sibling, would you then recommend mom get tested to be sure her levels are okay?
It depends on kind of what your working
where the lead came from.
Where it came from.
Yeah.
But it is not at all unreasonable if you think it's environmental to have either mom get tested or the baby sibling get tested.
That's a very good point. You're presumably the mother's not putting paint chips in her mouth.
One would hope.
But if it's environmental, then it really can be. All right, that's very helpful. I didn't realize. Wow, the mother completes chelation too. Okay, fascinating. Yeah. We're learning so much, Carly. What else you got?
I'm glad. I think that's all I have for today, at least.
Well, listen, I really enjoyed this. I learned a ton. I appreciate you doing this twice. First guest ever, purely my fault, so thank you very much. We have to come up with some sort of plaque or something to give you for that. But you are now a friend of the podcast. Thank you so much for your time, and we will call you for other breastfeeding-related topics.
I'm happy to help.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page. Create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do. Again, as always, please feel free to email me at tony.tarchichi, tarchichi@chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.